Thank you very much, Aviwe. That could be a long story, but I'll make it short. I was in the Medical and Dental Professions Board in 2003, around about 2003, when the then Minister of Health, Mantu Chabalala Masimang, requested the council or the board to consider a mid-level medical worker on the model of the United States and other countries in Africa. And there was reluctance on the side of the board, and I decided that it's something that I would like to contribute to, and I offered to be involved in developing the program, because my argument was that it is very appropriate in our context. And then a task team was put together where we investigated the possibilities. We went on an international trip to the States and to Tanzania, and we engaged with several universities, with professions, with the nursing profession, and came up around about 2005 with a report that set out the argument and the parameters for the clinical associate profession, as well as a proposed training program, which was then taken further into negotiations and for implementation with funding by then through the European Union, so that the first because then we had to work through the programs, the Council for Higher Education, creating the programs. By that time, we already formed the partnership between Wits, Walter Sisulu and UP. And through those three universities and the individuals there, we drove it until we had a national curriculum, which we submitted to the three universities and got the program going. We were clearly aware of the need for, let's say, the need for doctors, the need for clinicians, especially in the rural areas and the neglected areas. That was clear, and those of us involved in the program and development of the program were all involved in rural health or primary health care somewhere. And the task team that was working on that had the same thing. So it was basically, the aim was to create a cadre of clinicians who would be available, able and prepared to work in underserved areas in a team format, and support quality healthcare in those areas, specifically rural areas and underserved urban areas. At that time, the environment was such that we said that it's better to place them in district hospitals to assist the clinicians in the hospital, because the nurse clinicians were already working in the clinics, in the primary care clinics, and we did not want to create the impression that we want to create competition for the nurse clinicians. And we also did an assessment of all the procedural tasks that were done in district hospitals and found that there's a large range of those tasks which the clinical associates can assist with or do under supervision or as part of a team setup. So that was clearly the vision for that time, for the underserved, for the rural areas. And that then also guided our selection process or planning, that both the selection of candidates as well as the training was then planned to have a significant rural input into that. Where we are now is nearly 20 years later. The world has moved, the world has shifted. We went through the pandemics. So I would say the clinical associates have shown that they can do quality clinical care as part of a team. They also are often pushed to work quite independently and often without the necessary support. There's also quite a variation in what I would say acceptance and even respect in different situations. And so from where we stand now, and I could talk in terms of the NHI or not NHI. In my view, and my experience about our present cadre of clinical associates is that you are able to relate to people on all levels. That ability to relate to people, I've seen clinical associates relating to specialists, to family physicians, to lab people, to OTs, physios, in the hospital, nursing staff, at a very respectful and equal level. I've also seen them engage at clinic level with staff and then with community health workers, as well as with people in households, patients, etc. And I think that is a strength. So what is necessary in our healthcare system is coordination of care. There is a serious lack of coordination often in most of our healthcare. There's often a disconnect about what happens in the hospital, at the clinic, at the home, or even between professions, between service organizations. And worldwide, there is a movement to make care coordination a very important element of healthcare. And what I am advocating is that the clinical associates as a profession, including those that train them, occupy that space of care coordination as saying we can do many other things. being a holistic clinician. We can do that. We can do home visits. We can do all of that. But we are prepared to become the functional care coordinator in the team, which means that you easily move from ward round to community health worker, arranging discharges, making sure that this person is leaving the hospital, being in care at home, or being in care at the clinic or at another institution, and also assisting with the movement of patients from home to the clinic to the hospital, engaging with community health workers, and becoming the I'm reluctant to use the word specialist, but actually becoming the people, the go-to people in terms of care coordination. Because if care is well coordinated, if efficiencies go up rapidly. And because clinical associates know how things work in the hospital, they know how things work in the clinic, they know how things work at home, they know how community health workers work, etc. They can actually do that care coordination. They can still work under the in team with, say, a family physician or a clinical manager at a hospital or a district primary health care manager, etc. So it's not it is part of a team, but actually that knowledge of how do you create collaboration, how do you set up care coordination systems, how do you maintain it, how do you review it, that becomes an area where the clinical associates can excel. And then obviously in any NHI setup with the contracting units for primary care, care coordination is crucial. And then the clinical associates can easily step forward and say, we are prepared to do that. And this is what we have been taught, and this is what we can do. And there are the examples of where we have done that. We have examples in the work we do in mining communities, where the clinical associates would move between services and home and clinics and community health workers. But there are other examples as well. But I think as a profession and as the three universities that train clinical associates, I challenge us to take this up as a major issue and do that both for the sake of the profession, but also for healthcare and for the people, because then it will also give the clinical associate a particular area of expertise that would make you recognizable as well as needed and valued. We had this discussion with our deputy dean a few weeks ago, and actually what came out there is we need to be better at making the clinical associate recognizable in the health team. It may even be an issue of a uniform or a clear recognition. There should be no doubt that that is a clinical associate. And then to say, this is what we can do. And the term that came up there that needs to be understood and done is the clinical associate is a holistic clinician that drives the PhD agenda. Now, you can do a lot of things around that. But what is still to be done is this identity work, and then obviously the whole human resource work that hasn't been done, where Sanele's public protector report needs to be implemented. So I see the future as lots of opportunities, but definitely hard work with some uphill that needs to be climbed. But I believe that this will be done, this can be done with those, even those who are in this audience and those who are involved at the moment. Thank you.